Great. Thank you so much for having me. Let me share my screen and then I will introduce myself again. Let's see. Give me a moment.
You're good.
Let's try that again. Okay, are you seeing the correct screen?
Yes, you are good.
Okay.
Thank you.
Yeah, great. Okay, so my name is Sarah Roberts. I'm a professor in the OBGYN department at the University of California, San Francisco. And I am a public health researcher. And the way I describe my work is I study the ways that state-level policies affect the health and well-being of pregnant people and women, children, and families more broadly. And I am specifically today going to focus on research I've been doing about policies related to alcohol use during pregnancy. There we go. So I imagine people here know a key healthy people goal for decades has included increasing the proportion of pregnant people who abstain from alcohol. But very little progress has been made towards this goal. And one of the things that I noticed when I was looking at the Healthy People 2030 document is that it only includes one recommended evidence-based practice for the goal of increasing abstinence from alcohol among pregnant people. And this contrasts with the dozens of recommendations, including policy recommendations for reducing population-level harms related to alcohol consumption in general. So I'm interested in policy. And when you think about policies, the way I like to group them is to think about them as either pregnancy-specific policies, things like mandating warning labels or warning signs or requiring reporting to child welfare. Or we could think about general population alcohol policies, things like alcohol pricing or alcohol availability. And in fact, there was a recommendation to consider the possible effects of alcohol pricing and other general population policies more than 25 years ago. But until recently, until about a decade ago, very little research had examined any relationships between either type of policy and outcomes related to drinking during pregnancy. In the US, there had been no studies that had focused on state-level pregnancy-specific alcohol policies, and the only studies in the US that focused on general population policies focused on the minimum legal drinking age, although since I have done more work on related to this, I think it's important to remember that minimum legal drinking age is not a general population policy. It singles out young people. And then there's a single study on taxes. So the questions that we have that we were answering with the drug and alcohol pregnancy policy studies were to use legal epidemiology methods to answer questions related to state-level policy and pregnant people's alcohol consumption, looking at both the pregnancy-specific policies and the general population policies, and to look and see whether they are related to harms related to pregnant people's alcohol consumption. So the method that I referred to is called legal epidemiology. In short, Legal epi is a method for systematically looking at laws and policies and looking at the relationship between them and a range of health outcomes. So it is looking at law as the cause of health and disease, rather than looking at a pathogen of some sort or the built environment. It is looking at laws as the cause of health and disease. Happy to answer any nerdy and technical questions that people have, but for now, I will leave it at that. So first, I'm going to focus in on the state-level pregnancy-specific alcohol policies, and I have a list here of a few of the papers that we've published on this. The policies that we looked at include these policies, and these are policies that are tracked in APIS, the Alcohol Policy Information System, that is actually an amazing resource supported by NIAAA that tracks pregnancy-specific alcohol policies, pregnancy-specific drug policies, and then a whole host of general population alcohol policies, as well as cannabis policies. So we looked at mandatory warning signs, priority treatment for pregnant women and women with children, so essentially allowing pregnant women and women with children to go to the front of the line for treatment. Prohibitions against criminal prosecution, which really focuses in on the use of medical test results in criminal prosecutions. 3 different reporting requirements policies related to data collection, assessment and treatment, and child welfare, child protective services purposes. And then policies that define alcohol use during pregnancy as child abuse and neglect, or allow for civil commitment. In terms of how common these policies are, here's a graph that shows a little bit about trends over time in these policies, as well as how many states currently have these policies. So the light blue reflects how many states have these policies now. You can see that about half of the states have a mandatory warning signs policy, a reporting requirements policy, or a child abuse and neglect policy. You can also see that these policies have increased over time. The first of them were the reporting requirements for child protective services purposes and child abuse and neglect policies. And in fact, the first ones of those went into effect in 1974. And first state to have one was actually Massachusetts. So our specific research questions for this first set are, what are the relationships between state-level pregnancy-specific alcohol policies and pregnant people's alcohol use, birth outcomes, prenatal care utilization, substance use disorder treatment during pregnancy, infant morbidities related to maternal alcohol use, infant maltreatment, and severe maternal morbidities? We used a variety of different data sources in terms of the outcomes. We looked at the behavioral risk factor surveillance system, which is survey data. We have vital statistics records, so birth certificates, the treatment episode data set, and 2 different claims data sets. So market scan for private insurance data and Medicaid for public insurance data. And we looked at different outcomes in each of the data sets. Our Medicaid analyses are still in process, and some of that is those data are really, really, really challenging to work with, especially the task of matching maternal and infant outcome data. So here's a little bit more about the different data sets. The smallest one that we used was BIRFIS, that had 57,000 pregnant women in it. And the largest was the vital statistics records that included more than 150 million births. It includes all births for people who were born in the US, I believe beginning in the early 1980s through present, and then a 50% sample from those in the 1970s. I also noted places where there are more limitations versus fewer limitations to the data source. And just as you're digesting the findings, I think The BRFIS data are probably the one that has the most limitations. And then there are fewer limitations with vital statistics and market scan. And when we are finally ready to share the Medicaid findings, that will probably have the most limitations of all. So in terms of the summary of our findings, the first thing is that we found that most of the pregnancy-specific policies were not associated with alcohol use during pregnancy. And those that were associated had effects in different directions. Priority treatment for pregnant women and women with children was associated with more self-reported drinking. And then both mandatory warning signs and child abuse and neglect were associated with less self-reported drinking. That probably doesn't seem totally surprising, but when I show you the rest of the findings, this will probably stand out because it is the only one where mandatory warning signs and child abuse and neglect are in this direction. And I think it's important to note that these are self-reported outcomes. So if we think that one of the mechanisms through which these policies might affect people is through fear and stigma, it's also possible that when these policies are in effect, people are less likely to disclose their drinking during pregnancy on a survey. Moving to birth outcomes. What we found here is that half of the pregnancy-specific alcohol policies led to increases in low birth weight and preterm birth. These adverse birth outcomes were higher when any of the following were in effect: mandatory warning signs, priority treatment for pregnant women, prohibitions on criminal prosecution, and child abuse and neglect. We also found, I think it was preterm birth only, was higher when reporting requirements for assessment and treatment was in effect. I'm not showing a lot of numbers here because there's a lot to digest, and also because the numbers are not that notable when you're looking at them in odds ratios. We're able to detect small effects due to the large sample sizes. So we translated this into something a little bit more concrete. We estimated the number of babies who were born in a year due to these policies being in effect. So we estimate that about 7,000 babies are born preterm or low birth weight, related to mandatory warning signs, and roughly similar amounts related to priority treatment and child abuse and neglect, and slightly fewer related to limits on criminal prosecution. In terms of the findings for prenatal care, 3 of the pregnancy-specific policies were associated with decreased prenatal care use, and 1 was associated with increased prenatal care use. So as mandatory warning signs, child abuse and neglect, and civil commitment were associated with less prenatal care use, and priority treatment for pregnant women was associated with more prenatal care use. In terms of substance use disorder treatment during pregnancy, 2 of the pregnancy-specific alcohol policies were associated with increase in treatment admissions during pregnancy, and 2 were associated with decreases. Those that were associated with increases were those that use coercion as a way to compel people into treatment. That's both civil commitment and reporting requirements for assessment and treatment. In terms of infant and maternal outcomes, 4 of the policies were not associated with infant and maternal outcomes, and 2 were associated with increased adverse infant and maternal outcomes without being offset by a decrease in another outcome. That was mandatory warning signs and reporting requirements for assessment and treatment. 2 of the policies had improvements in one outcome, but were offset by associations with worsening in another outcome. That was civil commitment and priority treatment for pregnant women and women with children. And then 1 policy was associated with improvement in one of the outcomes here, and that was priority treatment for pregnant women. That was a lot, and so now I am going to show you how we're attempting to synthesize this. So down the left are the different policies that we looked at, and across the top are the different outcomes we looked at. Towards the left are the outcomes where we feel more confident in our measurement. So the infant morbidity is related to maternal alcohol consumption, infant injuries consistent with maltreatment, adverse birth outcomes, and severe maternal morbidities. And then we have alcohol use during pregnancy, prenatal care use, and alcohol use disorder treatment. The other thing to note about the slide is that when there's a red circle, that's where there was a negative effect. An orange circle is where there was no effect. And a blue check mark is where there's a positive impact. Hopefully what you can see here is that there are very few blue check marks. There's also no blue check marks that exist without being offset by a red circle. And then there's there's quite a few places where the red circles are predominating, that we can see just a lot more red circles than we can blue check marks, or in fact, orange circles in many of the cases. The two that I specifically want to draw your attention to are mandatory warning signs. That is both the one that is always surprising to people. And on top of that, it is also the one that has, other than decreased self-reported drinking during pregnancy, the most consistent adverse effects of all of the policies. And then the other one I want to draw your attention to is reporting requirements for child protective services, where we found no benefit whatsoever for this policy. And I think that's really important to note because the purpose of all of these policies is to affect these outcomes. And so when they're not having any benefit for these outcomes, and we know that there are other consequences for the policies, it's really important to reconsider. So in terms of possible mechanisms, I'm happy to talk about this more during the question and answer. But I think the first that I alluded to earlier is that fear that getting prenatal care or treatment will lead to child removal. And I will say our findings are consistent with this in terms of there being less prenatal care and less treatment when some of the policies were in effect. It also seems that it's possible that mandated treatment can get people into treatment, but there might be a rapid and increased return to use as soon as they're no longer a treatment. One of the things that we found when we looked at pregnant people's views on warning signs for cannabis use during pregnancy is that pregnant people do not trust information in the warning signs. And then I think a possible explanation also is that there's not enough funding for treatment, even when priority is mandated. So in terms of the conclusions for the pregnancy-specific policy part of this presentation, I think what we can say is that at best, most of the pregnancy-specific alcohol policies do not affect use during pregnancy, prenatal care, or birth outcomes, or infant and maternal outcomes. And at worst, some of the pregnancy-specific policies lead to decreases in prenatal care and treatment and increases in adverse birth outcomes, infant morbidities, infant maltreatment, and severe maternal morbidities. And then if you take nothing else away from my talk, I hope that you'll take this. Harms from alcohol use during pregnancy come from use itself and from the policies implemented in response. So usually when we talk about harms from alcohol use during pregnancy, and frankly, harms related to drug use during pregnancy, we talk about the effects of the substance use itself. What these research findings indicate, and it's consistent with other research findings, is that there are harms that come from the policies implemented in response. So it's really important when we're talking about potential adverse effects from substance use during pregnancy in general, and alcohol use during pregnancy in particular, that we focus not only on the effects of the use itself, but really make sure we're bringing into the conversation what are the adverse effects that are coming from the policies that are implemented in response. And I would argue that these findings also suggest that new policy approaches that reduce harms related to alcohol use during pregnancy are needed. So a key question is, what might some of those be? And specifically, is it possible that state-level general population alcohol policies, reduce harms related to pregnant people's alcohol consumption. So when we're talking about general population policies, the types of things that we looked at are alcohol availability and drunk driving policies, so blood alcohol concentration laws, government monopoly control over retail spirit sales. So can you buy liquor in a private business or only in government-run stores? Availability of heavy beer and spirits in gas stations, at grocery stores, prohibitions on spirit sales after 10 p.m., and bans on Sunday spirit sales. We also looked at a whole bunch of different taxes. So beverage specific, so beer, wine, and spirits, ad valorem taxes, volume-based taxes, and sales taxes. I'm sharing here some of the information about the policy availability and data sources. Not because I expect everybody here to be interested in the nitty-gritty aspects of these data sources, but because it's important to note that these data are not consistently available, either in terms of the years that we looked at in our analyses, or for all states. Tax data are only available in states where alcohol sales are privatized, not in government monopoly control. So we only have them in a subset of states. The other thing to know about the general population policies is that there's a lot less change over time in these policies. They've stayed much more consistent over time than the pregnancy-specific alcohol policies. I think that's probably important from a policy perspective, but it's also really important from a research perspective for this type of analysis. It's just trickier to do the type of analysis we're doing when there's less change over time or when there isn't variation across states. So there's many more limitations to these analyses than the analyses of the pregnancy-specific policies. I realize that I have the state of Washington here because the last time I used this slide was in a presentation in the state of Washington. But it is actually also worth just naming Washington for a moment. Washington is the only state that changed from having government monopoly control over spirit sales to privatize sales during the study time period. Here's the trends in the beverage-specific taxes. These also did not vary much over time. They've stayed really quite steady, as has the number of states with these different sales tax policies. So in terms of our research questions, they're really quite similar to the previous research questions, except that the policies we're focusing on are the general population policies. And then we're not looking at prenatal care here because our hypothesis, we couldn't come up with one in terms of thinking that through. And then we're looking at drinking among women of reproductive age rather than drinking during pregnancy, because we have a better data source with better alcohol measurement for looking at drinking among women of reproductive age. And also, I think it's really important to note that people typically do not start drinking once they become pregnant. People who are drinking when they are pregnant were drinking typically before they became pregnant and either continued that alcohol consumption or did not stop it completely. Here's the information about the different data sets that we used again. It is generally pretty similar to what I showed you before, with the difference that we use the National Alcohol Survey rather than the Behavioral Risk Factor Surveillance system for the alcohol consumption data. Here's the information about the different data sets. You can see that the National Alcohol Survey has fewer people. That is a trade-off. It has fewer people in terms of sample size, but it is much better alcohol measurement. And then we used more years of vital statistics data through 2019 based on when we did those analyses. So in terms of findings, terms of drinking among women of reproductive age, hopefully one of the things that you'll see here as I begin to show these to you is that overall, it's not completely the case, but there is much more green than red here. Green indicates where the policies are having the effect in the direction we would hope for, where outcomes are improved when those policies are at effect, and red in the opposite direction. So rather than going into detail, because it's probably hard to track all of these details, I'll say multiple general population policies were associated with decreased drinking among women of reproductive age, particularly government spirits monopolies, bans on Sunday spirit sales, and lower BAC limits. There were a few weird findings for birth outcomes, but there were multiple general population policies were associated with improvements in birth outcomes, particularly government spirits monopolies, and then beer, wine, and spirit sales taxes. There's some funky findings for prohibiting alcohol sales at gas stations and grocery stores. We use blue for the treatment entry during pregnancy because for the general population policies, the logic of the directions don't hold in the same way. You can have decreased treatment during pregnancy because there's less need for treatment, or because the policy prompts more people who might need treatment to get into treatment. We don't know for sure which direction it is. And then for the infant, oops, got behind. And then for the infant and maternal outcomes, you'll see that it is more green than red. Multiple of the policies were associated with improvements in infant and maternal health outcomes. For this next slide, I'm going to just orient you to the one difference from the way we synthesize the pregnancy-specific policies. Instead of using orange, we're using light blue. And we're doing that because for the pregnancy-specific policies, if the policies aren't having an effect, that's a concern because these are the exact outcomes they should be affecting. But for the general population policies, if they're not having an effect on these outcomes, that doesn't have a larger implication about whether that policy is helpful from a health perspective or not. So hopefully the first thing you can see here is there's a lot more blue here than on the previous synthesis slide. There's a lot more blue check marks. There's a lot less red. There's a number of places where there are only blue check marks without being offset by a red circle. And the most consistent policy in terms of having a protective effect for these outcomes is government monopoly control over retail spirit sales, and then prohibiting spirits sales in gas station also has a consistent positive effect. Stricter blood alcohol concentration limits also appears to be having a positive effect, as do prohibiting Sunday sales. Prohibiting sales in grocery stores, prohibiting sales after 10 p.m. It's not totally clear whether, though, as well as prohibiting heavy beer sales in gas stations. Those are ones where it's not a consistent benefit across the board. When we look at taxes, you'll see that this looks pretty similar overall. We see quite a bunch of blue check marks, and we see a number of blue check marks where we really don't see very many that aren't offset by red circles, specifically for wine sales taxes, spirits volume-based taxes, and spirit sales taxes. Those are places where we noted some consistent benefits. So what can we take from this? Going back to what I said before, harms from alcohol use during pregnancy come from use itself and from the policies implemented in response. Pregnancy-specific alcohol policies are ineffective and in some cases harmful to pregnant and birthing people and infants. And general population alcohol policies might be a more effective alternative to reducing harms related to pregnant people's alcohol consumption. If people were looking for an evidence-informed policy agenda related to alcohol and pregnancy, this might look like getting rid of most of the pregnancy-specific alcohol policies, keeping and strengthening effective general population policies, such as government control over spirits retail sales, as well as wine and spirits taxes. And people who are working on general population alcohol policies might point to pregnancy and birth outcomes in terms of the benefit of general population policies. I want to acknowledge our funder, NIAAA, who I appreciate for supporting this work, although I will very much note that the content is solely the responsibility of myself and my co-authors and does not necessarily represent the official views of NIH. I want to acknowledge our colleagues at a range of different collaborating sites at UCSF, at the Alcohol Research Group and Public Health Institute, the Pacific Institute for Research and Evaluation, Penn State, as well as our amazing consultant, Lori Drabble at San Jose State. So with that, here's my contact information, and I will stop sharing now for questions.
Thank you so much, Sarah. That was really great. I love how you're able to synthesize everything into the charts and using the color coding. I think it really helps to kind of bring your results to across, right, in the different communities. I'll open it up if anyone has any questions. I'll kind of start with one I had from one of your earlier slides, actually. Maybe it's a little bit of a nerdy question, but that's fine. When you were presenting earlier with your pregnancy-related policies, and you were breaking it down by the excess numbers of the outcomes, I was just curious about a little bit more about kind of where those numbers come from and how they're generated. And then my second follow-up question to that is, I heard in your last part about your discussion about, these policies just aren't doing anything. But the graph that I'm referring to talks about harms related to the policies. So I just wanted your perspective on how much focus in your dissemination of your work do you focus on harms versus like a null effect, I guess.
Great question. I'll answer the latter one first, which is, it's helpful to hear that that's what came across. What I'm trying to communicate is that at best, like singling out pregnant people isn't helpful and is just doing nothing. But in fact, we're really seeing harms from a number of the different policies. And I think we have enough evidence at this point to recommend a pause on adopting new ones of those policies and then to begin to de-implement some of them. I think the ones in particular that we have enough evidence to begin de-implementing is mandatory warning signs. And whenever I say that, people's response is, why do you care that much about that policy? And how could it possibly be that bad? And I was so surprised, and we have done so much work did we code it in the wrong direction? I've had other people do the analyses in other data sets. We have done a more rigorous causal analysis and have found the same thing. Those findings are under review. We've done additional survey work and qualitative work related to mandatory warning signs related to cannabis and pregnancy, as well as a rigorous causal analysis for that, and have found the same thing. So I feel very confident that those policies aren't working. And then when I recently went in and looked, most of those policies were adopted in the 1980s and 90s, and the language in those signs has not been updated since then. Mm-hmm. So just to help with that, to make that really clear, I think the other policy candidate for focus in terms of de-implementation is reporting requirements for child protective services, and probably for assessment and treatment as well, but we found no benefit to the reporting requirements for child protective services policy at all. And we know from our work with community members who are directly affected that that policy has a number of adverse effects on people's experiences. The nerdy technical question is that we did post-estimation margins commands to look at the predicted probabilities of these outcomes when the policies were in effect versus not in effect.
Mm-hmm.
And then we looked at the total number of births in states that had those policies in effect in 2015, and then applied the differences between those predicted probabilities to those numbers. So it was a pretty crude way of estimating it, but essentially using post-estimation margins commands to get predicted probabilities and then applying that to the underlying population.
Okay, thank you.
Yeah.
Liana, you have your hand raised.
Yeah, so thank you so much for such a great presentation and all the work that you put into all this. And I also like how you made your point really clear on both of the slides. That was great. So yeah, I have some questions. So first is you were talking about margins and the predictive probability. I'm not the greatest when it comes to statistics, okay? So this question might sound really stupid, but like, what was your margin where you were like, this is definitely a harm? Was it like on the edge, or like close, or did you have like a really obvious amount of a difference that it had to be, for it to be considered a harm?
Great question. We've used statistical significance at p less than 0.05 as our criteria for whether or not we say something has an adverse effect or not.
Mm-hmm.
And so I think it's tricky because some of our data sets have, more than 150 billion people in them. And so the odds ratio is really, really, really small. It will often be something like 1.02. But when you translate that to the population level, that's a lot of people, right? 7,000 people is a lot of, or 7,000 babies being born low birth weight in a given year related to a policy is quite substantial. The odds ratio itself isn't that substantial. So we really have been looking at whether the findings are statistically significant or not.
Okay, great. I think that's such an important thing to make a point about, because when it's presented to the government and of course our people on the wider scale, right, when they see the odds ratio, they may not think it's that important. But then when you talk about the number of babies and how important it is, how important that number is, because I think like we care about people, obviously, like that's why we're here and we're in ASAM and stuff. But I feel like on the like wider scale, like policy perspective, business perspective, like they tend to put the focus on numbers, So yeah, go ahead.
Yeah. And I mean, we also, in the paper that we published with those actual concrete numbers, we attached some costs to those as well. And that got a lot of attention when we did that.
Okay.
Yeah. So I will say the question of when to do that is really tricky. So we aren't doing that across the board. We're only doing it when we feel really confident in our findings that, for some of them, the findings are more sensitive and not robust to how we run our models. And we still publish them anyway because they're important in terms of just larger patterns and consistency. But we're very mindful of not generating numbers like this for every analysis that we do. And I, as somebody who digests a bunch of research using methods like this, there are some journals that are always pushing people to come up with numbers like this, even when I think there's a lot of limitations to the models, and then people attach to these very specific numbers. And so I think it's a really important thing for researchers. Just because we can generate a precise number doesn't mean we always should. And so throwing that out there as well.
Thanks so much. And I have another question too. Now I'm like super curious. I don't know if you kind of went into it in the beginning of your presentation, but the mandatory reporting, that policy, do you have an example of like the kind of language? Because that one seemed like just really bad. You know, like, I mean, what is it? What do you think is the reason for possibly like how bad it is? I mean, is it the language per se? Is it the way that they are maybe presenting it or where it's being applied? I don't know.
Are you talking about the mandatory warning signs
Sorry,
or the different reporting requirements?
mandatory warning signs. That's what I mean.
It's a great question. I think that it's right. I mean, these are the signs that you see. I'm sure you've seen them, right? They are the signs that are posted when you are in a restaurant or in a public place or you're somewhere where alcohol is sold that say warning, government warning, drinking alcohol during pregnancy can cause birth defects or increases risk for birth defects. Yeah, it's those things. It's the policy that mandates the posting of those. And from, let me say, I am hoping, I'm working on a grant right now so that we can try and do more survey research and qualitative research to understand the mechanisms going on. I think the likely mechanisms that I think are plausibly going on that I want to check and test in research are that I think the signs aren't resonating. There's a bunch of message fatigue. The language hasn't been updated since the 1980s and 1990s. I also think that sometimes they're scaring people. I think people also don't trust government warnings, particularly in our current context. Yeah, so I think that's some of the explanations. And then I also think that they may contribute to stigma. That's part of what we found in relation to the cannabis wordings. And so when they increase stigma, it keeps people away from care. And then we've also heard anecdotally that in places where people are, where prosecutors are criminally prosecuting people related to drinking during pregnancy, that there are sometimes instances where they use the fact that there's a warning sign as justification for saying somebody should have known to not be drinking during their pregnancy. So it's also possible that people are experiencing them as part of a threat. And that is then also driving them from care. So I think the answer is there's a lot of possible explanations and we need more research to figure out what is going on.
Thank you so much. Great work.
Thanks.
Does anyone else have any questions for Sarah? Well, I would just like to echo a big thank you, Sarah. That was a great presentation. Thank you so much also for the discussion about, again, this population level data when you're looking at policies and being mindful of how that gets translated to the public. And I just really want to really emphasize a great thing you pointed out is that you really do a lot of work to make sure we have confidence in your findings, right? And I think that is important to know for the ethical, right, and responsible conduct of research that we always talk about, which is highly important for all research dealing with health, but especially in the substance use world and especially in the pregnancy world. So I just want to highlight that as just a kind of an exemplar example of, when we're doing this population level work, especially when you're translating those findings, especially the ones that you're saying, we're going to translate this into the excess number of births, right? You know, but being mindful, I am 100% sure of this finding. I've replicated it. I've given my data to other people. And now I've decided that, yes, I'm going to stake my name on this and translate it now into numbers that matter. I just want to just highlight that just from a methodology standpoint of how to run research in the translational setting is a great example. So thank you for discussing that too.
Thank you.
Great. Well, thank you so much again for presenting, and thank you everyone for coming. And I'm going to send this link out later on and also post it online too, so feel free to share it with others. And everyone have a great weekend. Thank you.
Thank you, Caitlin. You too.